Hey, y'all.
What up, y'all? And welcome to the Birth Squad podcast. If you've been riding with the squad,
hey, fam.
And if you're new,
welcome to the squad.
We're your hosts, Dr. Ijama Kwandu and Dr. Kamisha Thomas, two licensed obstetricians and gynecologists, as well as best friends.
We use real stories to educate about pregnancy, birth experiences, reproductive health, and all things in between.
And while we hope you love learning about our podcast, it is not intended to be a substitute for medical advice, diagnosis, or treatment. Please consult your healthcare provider for your specific care.
So to learn more about us and for more information, please visit our Instagram at The Birth Squad and our Twitter at _The Birth Squad.
Please keep in mind that the following episode may cover topics that could be triggering to some individuals. Listener discretion is advised. Meet Aparna. She's the next badass birth warrior who will share her story to help the squad navigate through the complex and inspiring journey of pregnancy, labor, birth, and motherhood.
In this episode, we're talking about a very common issue, both in and outside of pregnancy, that a lot of people don't talk about: depression and anxiety. During the interview, you may notice that there's some medical terms or jargon, but don't worry, we got you. We have included definitions and explanations in the episode description. So please listen up and enjoy her story. Please also be advised that this may be triggering for those who have struggled with mental health issues. All right, squad, we are back today, and I'm excited to introduce Aparna. Welcome, Aparna.
Thank you.
I'm so excited to have you here. Do you mind introducing yourself to the squad? Just let us know a little bit about yourself and, your family.
Yeah, absolutely. So my name is Aparna Chatterjee. I am a reproductive psychiatrist in Chicago, Illinois. My husband is a cardiology super fellow in heart failure, and we have a beautiful little boy named Devin, and he's 18 months. I primarily work in the reproductive space. So essentially, I did my training in general psychiatry, but I also did an additional fellowship year in women's mental health. So I mostly work with patients who are trying to get pregnant or postpartum, or patients in the premenstrual symptom space or perimenopausal symptom space. And as a psychiatrist, I work to manage medications typically and provide information about the efficacy of treatment and certainly the low risk of taking a lot of different types of treatment during those times.
Hold up real quick. Aparna is what?
Aparna is a reproductive psychiatrist.
Hold on, though. But what is the difference between a psychologist, therapist, and psychiatrist?
Now, Kamisha, that is a really good question. So let's start from the top and go through each one. A psychologist is someone who observes people and environments in order to get a better understanding about how we think, feel, and interact with others in society. A therapist or psychotherapist is an individual who is a licensed mental health professional who helps people cope with life's challenges and reduce the symptoms of mental disorders. Psychologists and licensed clinician social workers can work in this capacity. A psychiatrist, like Aparna, is a licensed physician who is trained to help treat mental and substance use disorders. These are individuals who can actually prescribe medication for management.
So, could someone have a therapist and a psychiatrist?
Absolutely. In fact, commonly patients who need medication to improve their mental health will have both a therapist and a psychiatrist.
So a psychologist is just a similar sounding term that's not quite related.
Kinda, but yes. Now let's dive back into Aparna's story. What was your path towards pregnancy and parenthood?
Like most physicians, I have a fairly type A personality. There was a lot of planning, I would say, from a timeline perspective. And honestly, a big part of my work had framed my timeline to some degree, just because you see a lot of infertility, and as physicians or just high functioning women, I mean, I think the age of deciding to start your family is extending. And I just think I definitely knew once I was done with fellowship that I wanted to start my family, because the thought was like, okay, if we want to have multiple, like I was aware of my biological clock. But yeah, so but it was very intentional. We were very excited, and we got pregnant. I realized I was pregnant, and so I'm like by myself at like 4 a.m. and I was really excited. And then I texted my husband, and he was definitely sleeping, so like I got no response. But then he was so excited, and he was like, "But are you sure?" And I was like, "Yeah, I'm pretty sure." But yeah, it was just a really exciting time. Honestly, for the most part, it was a pretty manageable time for me, pregnancy specifically. I mean, I think there were a couple moments of anxiety. I remember I got both of my COVID vaccines during like first trimester, and there was just like a very limited amount of information at that point. And so that was it was just a little bit nerve-wracking. The other point that I remember caused quite a bit of anxiety for both me and my husband actually was doing the genetic screening. But then that took another 2 weeks.
So what does Aparna mean by genetic testing?
Well, we offer two types of screening in pregnancy, and these are both blood tests. Number one, carrier screening. We're asking the question, are you a carrier for a genetic disorder that can be passed on to your children? This includes disorders like sickle cell, cystic fibrosis, and a few other disorders. You can get this done prior to pregnancy and obtain genetic counseling to review your options. Additionally, if you are positive for anything, then we recommend your partner also get screened to help with decision making. Number two, genetic screening. This asks the question, does your baby have a disorder like Down syndrome or other high-risk issues like a spinal cord disorder? In most states, this is a two-part blood test that is time sensitive. Part 1 is between 10 to 13 weeks, while part 2 is obtained from 15 to 20 weeks. And these results can take anywhere from 2 to 4 weeks to result.
Please keep in mind that these are screening tests. So if anything actually comes back positive, then we recommend diagnostic testing. That's a test that obtains the fetal cells. An example of one way to do that is with a procedure called an amniocentesis.
Okay, now let's hear Aparna's birth story. Please be advised that this could be triggering for those who have experienced labor and birth. We recognize and understand the significance of birth trauma.
I was 39 weeks exactly, and my water broke with no contractions at like 1 a.m. I went to the bathroom, and it was just like clear water just continuously, or fluid just continuously coming out. What people don't realize is like you keep like leaking, like it's just clearly amniotic fluid coming out. And so yeah, I put a pad on and went and woke up my husband, who was very discombobulated. And then we actually walked to the hospital because we lived like 15 minutes away. So that was what we did. So, but it was fine. And then they did the tests where they check for like Ferning to confirm. But I had no contractions. So I'm just sitting in triage for a very long time, because understandably, like other people are getting admitted before me just because they were progressing a lot faster.
Okay, Aparna talks about ferning. What does that mean?
Well, when you tell us that your water has broken, then we want to make sure that that's what's going on. Remember, the amniotic sac or bag of water is a barrier to infection. If it's no longer intact, then it changes our management options. Keep in mind that during pregnancy, pee or even normal discharge can resemble your water breaking. So there are a few ways that we can confirm that it has actually broken. Number one, your provider may use a speculum and see if fluid is pooling in the vagina. This is a pretty good clinical sign that the amniotic sac has ruptured or opened. Number two, ferning, like Aparna mentioned. Your provider does this by collecting some of that fluid and placing it on a slide. Remember, those slides from biology grade school? Yes, we still use those. We look at the dried fluid under a microscope, and if it's positive, then the cells will literally look like a fern leaf, which is pretty cool. Number three, pH test. Your provider can collect the fluid from the vagina and test the pH. The amniotic fluid is basic in comparison to the vagina. The presence of amniotic fluid will turn the pH paper blue. And number 4, ultrasound. Ultrasound is often used to assess how much fluid is around the baby. Low fluid can be indicative that the bag of water has ruptured.
One thing I like to remind our birth warriors about is that if you break your bag of water, then you will continue to leak throughout labor until the baby is born. This is because the baby actually produces the fluid. So while the baby is still in your uterus, that fluid will still be coming out. Now let's dive back into Aparna's story.
And so we finally get admitted, get on Pitocin, and that starts inducing contractions, which are painful for anybody that wants to know. So I actually was on Pit for 6 hours, and then it was very painful. At that point, I was like, this is ridiculous. And then I got the epidural, which was amazing. Then we just kind of waited. Like it just, there were multiple times when they had to increase the Pit because I wasn't progressing as much. Like had only dilated like 2 centimeters after 6 hours on being in the Pit. And so they kept trying to increase the dose. And every time they would do that, Devin would decel, and then like that whole team would come in. And then like every time they would break the contraction, I already had pretty low blood pressure. And so then my blood pressure would get really, really low. And I was actually very calm because epidurals like made me very like calm and kind of groggy. And I was like, but my husband was just like understandably a little nervous. And then around 9 p.m., I was like, well, it's been about 21 hours. And so I was like, I know we're heading towards C-section. And so a couple hours later, the attending comes in and she was just like, yeah, I think we probably need to likely do a C-section. You're really not progressing and he's not tolerating, the titrations and Pit. And we were both very calm because we had already had that discussion. And she was just like, you guys are the calmest people that I've ever had this conversation with. Yeah. Then at that point, got like more epidural, and that medicine, especially at that dose that like you have to get a lot to be prepared for a C-section, made me very sick. So like I was like vomiting a ton, and then we got wheeled to the OR. And it's really interesting because like you are just paralyzed, from the waist down, and they need to like move you from your bed to the OR table. And I was just thankful once it was a very quick procedure. And once they had him out, like he cried pretty immediately because like that was what I was looking to hear. And it's funny because they asked like, do you want to hold him? I was like, no, I am so tired right now and groggy and I'm vomiting. And like, I was like, I'm good. My husband, I'm not crying at all. Josh is much more sentimental than me. And he's tearing up, and he of course like they put Devin's cheek right next to him. It was like really sweet. Yeah, we delivered, they sutured me up and then went into recovery, and kind of like immediately they kind of put him on me and tried to like encourage latching and things like that.
Now, Aparna talks about getting Pitocin. Remember, if you aren't contracting on your own and your water has broken, then it's a good idea to help your body actually contract. That we do by using Pitocin.
What about the extra medication she mentioned during her C-section?
Well, we want to make sure that you don't feel the surgery. So the anesthesiologist will give you a higher level of medication through your epidural, which can sometimes lower your blood pressure.
Got it. Okay, let's hear how postpartum went for Aparna. But please be advised that this could be triggering for those who have struggled with mental health issues.
Postpartum was a very difficult transition and time and experience for me. I had an extraordinary amount of postpartum anxiety, and it truly built just an enormous amount of empathy for me, for my patients. Like I think it's really just continued to strengthen the relationships that I have with them, and I'm able to share like just an added layer of, I think, support for them. I remember the first day in the hospital postpartum, I had a lot of trouble getting my son to latch, and that was very stressful. That is probably one of the primary initial understandable like challenges that typically comes up like when I first meet somebody, particularly postpartum. And breastfeeding is very physically and emotionally demanding, and something that I was highly aware of. And actually a conversation I had with my husband prior to delivery definitely was like, I want us to have these conversations prior to going in. And one of them was actually about breastfeeding. And I was like, listen, sometimes it's hard, like whether it's difficult to latch or just your supply is low, or mastitis, or like whatever potential, issues there could be. I was like, I want us to be open to the concept of like fed is best. And, like my mental health is actually really important. Like I want to make sure like we're going in with that mantra. And he was very supportive of that. And yeah, we had a lot of trouble latching at first. And I was just sobbing. I remember that was very, very, very stressful. But that got a little bit better. So like I think it helped to eventually just go home. But then we got home and things felt really calm. And I was like, okay, like we just kind of have to get through the first couple weeks and then like things will click. Like that was kind of my thought. And so the first couple weeks, I felt like I was just surviving. I was not sleeping a lot, but I was just trying to figure things out. The latching was getting better and like less painful and all of that. So I thought we were getting into a better progression. But I think the sleep really got to me. Like I think that ultimately was what was the hardest part, actually, which surprised me because I had done a lot of night shifts and moonlighting and all of these things. And I really thought I would be prepared for that. But, I think what you don't realize, or what I didn't realize, was like, the difference is like, even when you do, 2 weeks of nights or whatever, there's still a night off. The thing about maternity leave is like you are fully responsible like the whole day, basically the whole night, and not every baby is the same. And I just felt like a failure. I felt like I was drowning and I felt like I couldn't figure it out. And like every day, every week, something different was coming up. And it really, really, really caught up with me. I really ended up having an inordinate amount of anxiety and just felt like not good enough. Like I just couldn't hack it. And I was just like, I think just the lack of knowing when he was going to wake up also was really hard because it then ultimately made it very difficult for me to fall asleep, despite how tired I was, right? Which is a huge marker of anxiety. It's like the number one question I always ask is like, are you able to fall asleep, when baby is sleeping? Because if you're not, it's like typically related to being understandably very anxious. So yeah, it just really progressed for several months of high anxiety.
I just want to take a moment to highlight this. We all suffer from anxiety in some form. Even psychiatrists struggle with anxiety.
Seriously, what a great example of how common mental health issues are. So, how do you recognize normal symptoms of new parenthood versus larger issues?
Well, let's hear what Aparna had to say about baby blues versus postpartum anxiety and depression so that we can gain some more clarity.
So I'll start with postpartum blues just because that probably makes the most sense. So, postpartum blues is something that affects actually a majority of women postpartum, like probably 85 to 90% of women. And it's incredibly hormonally driven. And essentially what it is like the first 10 to 14 days postpartum, women can experience an inordinate amount of like irritability, tearfulness, feeling very overwhelmed. And I actually tell a lot of the patients I work with who may actually be on treatment during pregnancy, like despite being on medication that may manage anxiety or depression, it actually can't really reduce your risk for postpartum blues because that's incredibly hormonally driven. And so I find that to be helpful to kind of manage expectations of recognizing like, there's this first couple weeks that can be difficult. It's incredibly variable. Like for me personally, like, I mean, I definitely had moments of irritability or tearfulness, but it wasn't overwhelming. But I certainly have seen it be very, very, more severe in some cases. So it's very variable how that presents, but that tends to taper off within a couple weeks. And where I get concerned about postpartum anxiety and depression is really the persistence of symptoms of anxiety or depression kind of past those 2 weeks. So postpartum anxiety, I mean, when we think about anxiety in general, I mean, the way that I tend to describe it is just a lot of like what we call rumination. So just constantly thinking about like your task list, what is next, going down rabbit holes of like, the terminology we use for that is catastrophizing, a lot of what we call like racing thoughts, like very hard to stay in the moment, present, engaged, because you're kind of constantly just assessing and trying to figure out like, what do I need to get done next? And often anxiety can impact things like sleep and lead to a lot of insomnia. It often can impact things like your gut and lead to poor appetite or feeling really nauseous. It can, of course, in really severe cases, lead to things like panic or panic attacks, and can be very invasive. I tell this to people all this time. So, the brain structure that mediates anxiety is the amygdala, and that is a very primal brain structure. It's something that exists in every mammal, every reptile, for a reason. It's a huge part of survival. It's what tells us like things, it's safe or not. It's what keeps us on high alert. It's what provides vigilance. But the problem with what's going on now is like right now we're not needing to be aware of our surroundings to the point of like typically assessing if there's a lion or a predator that's going to eat us, right? And so that structure, while it continues to be valuable, I think a lot of people don't realize this, but anxiety is very adaptive. It's a huge part of like what leads to success. It's impossible to have growth without challenge and some amount of stress or anxiety, but there's often a clear line where you've then passed from like adaptive reasonable anxiety into pathologic anxiety, right? And a lot of people are finally starting to come back and talk about like it's actually really important to embrace and manage your mental health, because ultimately that is what will help you be more successful. So that is a very good way, I feel like, for me to explain what anxiety is. I think people can recognize depression, right? Like that's not an uncommon thing for someone to present to care. But I have a lot of patients who are new to care, who are new to a psychiatrist. And I think they are frustrated because they're just like, why can't I hack this? Like, this is something everyone does. Like, so many women have children. And what I really try to emphasize is, you likely had some pre-existing symptoms, but your ability to cope was different just because you didn't have a child, or like you weren't getting pregnant, or you weren't dealing with infertility. This is a high-risk time. Classically, we describe depression or an episode of depression as at least 2 weeks of feeling low, of a low mood, typically having what's called anhedonia. So that means not getting enjoyment out of activities or things that typically would make you happy. So even like reaching out to friends, reading a good book, watching a nice show, cooking, whatever it is. And then a cluster of other symptoms. So like often can impact sleep and appetite. So either lowering sleep and appetite or being like very hypersomnolent, so sleeping too much or eating, an inordinate amount. A lot of guilt. The phenomenology of postpartum depression is often very, very characterized by guilt, just feeling like a failure, just feeling like a lot of shame, a lot of internalized shame. Certainly can impact things like bonding for sure with baby. And then in really concerning severe cases can be things like feeling very hopeless or having thoughts of suicide.
When we talk about mental health, it's important to understand that this can lead to someone taking their lives. Worldwide, the estimate is that 1 million people die by suicide each year.
That is a harrowing fact. Death by suicide is a leading cause of maternal mortality and accounts for about 20% of postpartum deaths. So let's lean in as Aparna sheds some light on suicide ideation. She will also discuss when birth warriors should get help.
So passive suicidal ideation, where people will say, I just wonder if my family would be better actually if I weren't here because I'm not good enough and I think I don't bring anything to the table. And so I would just rather not be here. Versus what we call like active suicidal ideation is like specific plan, intent, and preparation for a way to take your life. The difference is, typically if somebody's describing active suicidal ideation, that is a psychiatric emergency. And like, we really do need to take them to a higher level of care, inpatient, and make sure that from a safety point of view that they're okay. With passive suicidal ideation, that can certainly progress, but it gives us a little bit of opportunity to hopefully be able to manage them. We may see them a little bit more frequently during that time, of course, but also create a safety plan like with family or other people that may be involved to kind of keep eyes on this person. I think in terms of deciding to seek help, understandably, it's a decision of when you are wanting to seek that help, unless there's a safety concern and somebody needs to intervene and provide help. I think the hardest thing that is hard for people to recognize is you don't have to normalize anxiety and depression, right? Like I think a lot of people just are like, well, this is supposed to be hard. Like, and it is. Postpartum is a really, really hard time, but it doesn't have to be that hard. Like it should be, it should also is allowing you to recover and to eventually thrive. And if you don't feel like you can see that, or you're not seeing a path there, then I think it's reasonable to start talking to somebody. Because I can say, even for me personally, I mean, the way I remember, I would just be like, okay, I have to get to this marker and then it'll be great, right? Like I was like, I have to make it to 6 weeks. And then by then, like maybe he'll be doing a longer stretch of sleep. This is where that will get better. Like I definitely certainly experienced generalized anxiety, have all my life. And I've always been very honest with myself about that and known that about myself. And I have taken a lot of pride in the steps that I have engaged in over the course of my whole life to really manage my anxiety, right? And so whether that was, I've done therapy a lot, I am a psychiatrist. I'm very insightful about behavior and the brain and emotions. And I was really in a really good emotional place. I think I forgot to probably mention that, but that was probably the most important thing. Like it was actually very valuable for me to be in a very stable place emotionally before bringing another person to this world. What happened in postpartum is, to be honest, like I actually regressed a little bit. I found myself becoming more irritable or having, picking fights with my husband or just not feeling my best, just feeling like a failure, like going back to probably how I felt in my teenage or early 20s, where you just have all these identity questions and you're just so unsure and have a lot of insecurity. And it was really, really internalized shame for me. It was a lot of internalized shame of like, I am not good enough. I don't know how to be a good mom to him. And I am not able to figure this out. And it took me several months to really see that because I just put so much on the sleep. But then as the sleep got better, there's always something that happens. Like you always feel bad about like, now he's not transitioning to bottles is a whole thing, and now transitioning to daycare is a whole thing, and now getting them on solids and like figuring out the nap schedule. Like there's always something to be done. I was just like, I have spent so much time and I'm so proud of who I am. I'm so proud of like how I've gotten to where I am. And my family deserves for me to be that person that decided to have the son and not the shell of the person that I ended up becoming. And yeah, it was a huge part of why I went back into therapy. It really was valuable for me to have conversations about like what is within the realm and like what is reasonable in terms of like that inevitable transition into the postpartum, and then what is becoming a little bit more of those rabbit holes and catastrophizing and ruminating. And with that, I mean, a lot of my sleep got better. Like there was just a lot of things that really, really, really helped.
That was really helpful information to understand the difference between postpartum blues, depression, and anxiety. Aparna will now share some resources and how friends and family can provide support to birth warriors.
Resources. So PSI, which stands for Postpartum Support International, is a very well-known organization that provides support for women from a mental health perspective, particularly through the peripartum period. So that's, trying to get pregnant or postpartum. Another really great place that I love to recommend to a lot of patients is called Mother to Baby, or mothertobaby.org, I believe is their website. And this is a great website that has a number of PDFs of information of a lot of different medications or substances actually that you could potentially take in pregnancy and postpartum, and the evidence that's available. And it's very patient friendly, but very organized and very evidence-based. So I think those are my two favorite resources. And then in terms of how like your partner or family or friends, particularly if they're noticing something, it's a touchy subject, right? Like I think that I think it can be intimidating, first of all, for someone to consider doing that. And also it can not be received well, right? If someone's just like, I don't think you're doing well. And maybe you need to go see a therapist. And right, there's so much that goes into that. I think stigma, unfortunately, is a huge part of it. What I try to tell people is you ultimately, unless it's a safety concern and like somebody needs to be hospitalized, like to some degree, you have to meet people where they're at. If you're noticing as a spouse or as a family member, someone, I would just say, I'm wondering if there's any other options of potential treatment that can be helpful because it seems like you're putting yourself under an enormous amount of stress. And I don't know if you're feeling like this is hard, or you're feeling like this is too much, but if you are, like, let's see if we can find someone that can help, right? And really emphasize like it just has to be a conversation. Because it does. I have a lot of patients who ultimately go on meds, but it takes us a while to get there, and it's totally fine. I think there's a lot of conversation of like, well, if I have to get treatment, if I have to get therapy, or if I have to get on medications for managing my anxiety or depression, like I can't hack it. And a lot of women that I meet they're high functioning people who have done amazing things in their career and have withheld an amazing amount of stress, right? And I think for a lot of people, what they don't realize is this is just another part of your journey. I mean, the peripartum period is a high risk time for onset or exacerbation of depression and anxiety. And so it is a high risk time. It's a perfect storm of like biologically, hormonally, it's a high risk time. Psychologically, it's a huge transition. And at the same time, like your ability to use basic coping skills like great lifestyle, diet, seeing friends, going on a run is really restricted, right? Particularly in those first several months. And so it takes time. And I often will tell people, like, just because we're electing to consider treatment right now, this isn't forever. Like, we think about postpartum as 12 months postpartum, which surprises a lot of people. I think a lot of people think of it as like, oh, it's like the first 6 weeks or the first few months. It's not. Clinically, we think about it as, 12 months because it's a huge developmental and transitional year. But I'll tell people, like, let's say we go on meds and it helps 9 to 12 months postpartum. And then after that, we can assess. And if you get to that point and you're just like, I think I'm in a much better place, I want to see if I can taper off, we'll taper off.
Wow. Aparna shared some amazing information. Now, Ijama, when you have a patient with depression or anxiety that needs more support than just therapy, what is the number one statement or question you get asked?
The number one question that I get asked is the medication safe for the baby?
Exactly. And what do you tell them?
I always say, taking care of yourself takes care of the baby. It's really important to prioritize your health. You are holding the baby. The emotions that you feel have an effect on your pregnancy as well. So taking care of you takes care of the pregnancy and therefore takes care of your baby. Okay, I'm going to get off my soapbox. Aparna is now going to talk about some data.
The gold standard of treatment are antidepressants. And don't let that name feel like a misnomer, which is the gold standard treatment for both depression as well as anxiety. There are multiple classes of antidepressants. The most common class are called SSRIs, or selective serotonin reuptake inhibitors. So in terms of SSRI treatment in pregnancy and breastfeeding, what I say is it's actually very well studied, much better studied than many other potential medications that people can take. Unfortunately, 20 plus years ago, the recommendation was typically actually to come off of antidepressant treatment just because people weren't sure if it was actually too high risk of a med. And unfortunately, I think that goes back to the conversation of like mental fortitude versus mental health pathology. Like, I think people were just like, we don't know if these are high risk meds and women can manage. And then unfortunately, there were really not great outcomes. There continues to at times be not great outcomes, suicide in particular. And so I think that is what has propelled a lot of research in this field. And people have identified that antidepressants and specifically SSRIs are actually very low risk. We have not identified an increased risk for birth defects in babies while moms take an SSRI in pregnancy. So I remind people that there's a background risk of about 3 to 5% for any baby to have a birth defect just because reproduction is complicated and it's error prone. But we have not seen any additive risk to that 3 to 5% because you were taking an SSRI. And that's really valuable because sadly, like we're thought of as like just a vessel and not a human. And that's not true. Like we're just as part of like the birth process as the baby is. We're just as part of pregnancy and postpartum as the baby is. And like we both have to be feeling well. So there isn't any information to suggest that there's any increased risk for birth defects. We also haven't seen that there's an increased risk for what's called miscarriage or first trimester loss as attributed to being on an antidepressant or an SSRI. The 3 low risks that we identify is 1, there's a slight increased risk for preterm birth. So that is defined as delivery prior to 37 weeks. And what I try to remind people is independently, anxiety can be an independent risk factor for preterm birth as well, right? So I often will say that specific risk sometimes tends to be a little bit of a wash, right? It can be attributed to untreated anxiety or even instability in mood, but also can be attributed to the SSRI itself. So that is one thing. And to be honest, it's not a high risk. Like I have a number of patients, I would say majority of my patients deliver term, but it's certainly one thing to consider. The second low risk that we describe is what's called persistent pulmonary hypertension in the baby, or PPHN is the acronym I'll use just because it's a little bit easier to say. This is not a birth defect. They define birth defects at conception, kind of first trimester development. PPHN develops in the second or third trimester of gestation. Fetal circulatory pathways work a different way when the baby is in utero, just because like the placenta is a huge aspect of essentially what is providing life and oxygen and nutrients and all of these things. And then when babies are born, there's some shunting in those circulatory pathways that need to adjust because now baby has taken an inspiration and is breathing oxygen and now needs to like expand its alveoli and use its lungs. And so in PPHN, that shunting change in circulatory pathways does not occur. In the general population, this can happen spontaneously in about 25 and 10,000 infants. And then moms who are taking an SSRI, this risk for PPHN goes up to 34 in 10,000 infants. So I always really highlight those specific numbers to express, the increased chance of this happening because you were taking an antidepressant is like a 9 in 10,000 chance. And it's certainly something that could happen even if you weren't taking an antidepressant. It's just really an uncommon experience. The final risk is something called neonatal adaptation syndrome. So we've seen when women take an SSRI or an antidepressant during pregnancy, when babies are born, up to 30% of infants transiently present with signs of irritability, fussiness, jitteriness, in some cases, some difficulties eating or feeding, in some cases, some difficulties breathing. So I always say a few things about this. One, 70% of infants don't present with really any of these neonatal signs. And of those 30%, I would say a majority present like irritable fussy baby, which I think would be very difficult to frankly distinguish from like any other baby. This is not a common outcome. And typically the thing is we don't see any long-term consequences from this neonatal adaptation syndrome. People always ask what this is. Is this withdrawal? Like, what is the baby going through? So they've actually tested that. They followed women that took an SSRI through the entirety of pregnancy, and then they followed women who took it for the majority of pregnancy and then stopped it like 2 weeks or a month prior to delivery. And what they realized was actually in both groups, 30% of the infants still demonstrated these neonatal signs. And so what that indicates is this isn't like true withdrawal, because you would expect for the women that had stopped it a month prior to delivery that, there wouldn't be that presentation in 30% of the infants. But we think it is likely some adjustment, right? Like some exposure to taking an antidepressant during pregnancy is now leading to these symptoms in some of these babies. But the important part is that if symptoms do present, it's often not noticeable, or it's transient and we don't see long-term outcomes. So yeah, those are the 3 big things. Otherwise, like things like developmentally, we really haven't seen an impact on babies in terms of like IQ or increased risk for things like childhood mental health disorders. So that'd be like ADHD or autism. We have not seen that being attributed to moms taking SSRIs in pregnancy. And breastfeeding, it's a very, very low risk option. It transfers to the breast milk at a very low amount, where we typically don't see negative adverse events in babies when moms are breastfeeding. I often emphasize stability is much more important than necessarily being on just the one med that everybody's talking about. And that is really important because I think a lot of well-intentioned providers, like even OBs and primary care doctors, even pediatricians, like for sure want to manage and be aware of mental health symptoms during the peripartum period, and understandably bring up Zola because like that is what people are comfortable with and that's what a lot of people have heard. But then that unintentionally then sends this message of like, well, that's the only one that's safe that you can take in pregnancy and postpartum or breastfeeding, and that's not true at all. Like, first of all, I never use that word. It's not, to say a med is safe is doesn't really make a lot of sense. It's low risk. Like that is the identifiable part of it, right? This is a low risk treatment. Just like it's not necessarily safe to have untreated depression, anxiety all the time, right? It's the same concept. It's like this is a low risk treatment. And it doesn't just have to be Zola. So timeline typically is 4 to 6 weeks, is what it takes to truly see effect at a therapeutic dose to it. But I will tell you, remarkably, especially in like the postpartum, I often see people start to see benefit even within a couple weeks. It's kind of remarkable to me.
If someone is on an antidepressant, is it safe for them to just stop the medication abruptly?
No. So you can get withdrawal from serotonin, which is very uncomfortable. It's not dangerous per se, but it feels like the flu. Like you just can have a lot of nausea, jitteriness, incredibly uncomfortable. And so if somebody wants to come off their medication, you certainly should do that in consultation with a physician, who can help you taper off and let it be more comfortable.
If you were talking to a friend or a family or someone you care about, what's kind of the one thing you want to have them take away from, our discussion about all of this?
The biggest thing is that not everything is what it appears. I think there's a lot of, and social media, I think, has a great element, positive element to it of connection, but it has also led to a lot of misrepresentation of what this experience is like. I think even in the most stable, physically, mentally, like situation, it is impossible for the whole entirety part of pregnancy and certainly postpartum to just be really just this beautiful, stable, wonderful time. It's an incredibly fulfilling and rewarding time, of course, but I do think it's important to emphasize that this is a very challenging transition in someone's life. And I will tell you personally, like, I don't even know if which thinking back, I almost laughed to say this, but I don't even know if I actually embraced that sentiment going into postpartum. Biggest thing I learned is embrace that it's a transition and be okay that you may not always have it together or know what you're doing. And I think that can be a pretty hard thing to embrace. I think that's actually what surprised me the most about postpartum was it is another just crucial aspect of your journey. Like this is still a huge part of your identity formation. And it's okay that you're continuing to develop your identity because motherhood was not something that I knew anything about really before this. When I thought about becoming a mom, like I was like, oh, well, I want to be together so that I'm like really solid for my kid, which is really valuable, by the way. But it's okay if you're not. Like, it's okay if you are needing to really lean into the fact that this is a transition and you don't have it all together and like you can't figure out the balance, right? Because certainly as a society, we have very limited resources to really support certainly women, but parents, from a poor maternity, lack of maternity leave policy to just no support financially or physically from a childcare perspective, right? There's a lot of things going against us societally. And so I don't think enough people recognize that, right? Like I think a lot of people think maternity leave, they think of it as like vacation. Like they're just like, oh, like how is that time off? It's like, this was a recovery period, right? Like this is, and like, it's just because there's no messaging. And I want that to be so clear. Like, this is not this beautiful, always time off. That's not what this is. Like, I'm bringing a human being into this world who I am trying to help survive. I am trying to do that, and I'm trying to recover physically and emotional and get to a place where me and my family unit can thrive. I think the biggest thing that caused me anxiety was I was just like, I don't know when this is ever going to feel normal again, right? Like I was just like, when am I going to be able to feel comfortable leaving him so that I can go see a friend or go travel or be at work and not constantly have him on my mind. Because that's what I thought the rest of my life was going to look like. I mean, it's amazing. Like at this point, like I can't imagine my life without my son, and I am so much more fulfilled and so much more rewarded, and I feel more engaged in every aspect of my life because motherhood is part of my identity. And that is where we're trying to get people to go. And if it takes some time to get there, that's okay. And if it takes some treatment, whether it's therapy or group support or medication, that's also okay.
Well, thank you so much for sharing, your expertise and, your personal journey. And so we really appreciate you being part of the Birth Squad.
Absolutely. This was wonderful.
Well, y'all, thank you for listening to the Birth Squad.
We're going to continue sharing stories from more badass birth warriors because at the end of the day, you are the experts.
Remember, as you navigate your healthcare journey, that you are beautiful, you are brilliant, and you are brave.
We at the Birth Squad would love to hear more from you. Tell us what topics you'd want to hear more about. Hit us up on Instagram at the Birth Squad and on Twitter @_the Birth Squad. Most important, make sure to share this episode with your squad. Until next time, I'm Dr. Ijama Okwandu.
And I'm Dr. Kamisha Thomas. Peace, love, and solidarity from the Birth Squad.
Check out the podcast description for the explanations on some of the terms that were mentioned in the podcast.
In the description box, you can find out more information about Dr. Chatterjee and her practice at Meridian Psychiatric Partners. You can also follow Meridian on Facebook and Instagram.